So a little about how we started. I already told you all. So this is in our Nova. When I started in 1996, my Nova Hospital, at the inauguration brochure itself and my letter pad also, I used to have Nova ENT Hospital Endoscopic Sinus Surgery Center, and then I have incorporated ENT specialty clinics, special clinics like, to cover snoring, allergy, vertigo, speech and hearing, all these aspects in one place, like ENT related special issues, special problem, to focus on those things. But now only I could start this in a comprehensive way. In 1996 itself, or around 2000, I bought an ENG machine to deal with the vertigo patients. I bought a CPAP and sleep lab machine somewhere around, I don't remember, long back, around 2005 or so. I bought a sleep lab machine, myself and our boy who is working in our hospital, along with Sai Kumar. I took Sai Kumar also for a workshop on sleep medicine, sleep and snoring in Bombay. We all three went. Sai Kumar joined with me. So now the way I visualized, the way I wanted to do, I think now we have come to that stage. Now we have started with forming the team like that, a comprehensive approach for the snoring patients who come with, as I said, comorbidities, obesity and all. So this is the design which of the flow chart made by my son, the left one, and as per that, Anil designed these protocols, how the patient will go. When the patient comes to us, the center, how they will go. So starting from the entrance to this is the flow chart Ashish made and shown to Murthy Garu 6 months back. And later on we designed these things. In what all we have done in the pilot project, I am telling about this to begin with. So the patient will come here, counseling, and then all those things, he will pass to ENT consult. The first thing what they need is a ENT consultation, because I'm not telling this because I am a ENT man, but the snoring starts in the throat. Snoring is because of obstruction to the airway. The coin obstructive sleep apnea, itself shows there is an obstruction where upper airway obstruction, whether it is complete or partial. So the reasons in the upper airway obstructions have to be seen first. Obesity is contributing to the obstruction by narrowing the throat. So it has to start with evaluation of the patient, and the patient also comes to us only first. They come to us only first. And then after evaluating, the comorbidities will be there, obesity will be there, we see. But what to do with that, we used to worry. Now we have come to the solution. That's how we have formed the team, and that's how the patient will go in our center. With a flow chart like that, they will go. The physician will see next, they will assess the lab reports and all those things. Then after that, we decide, both of us, who has to tackle the patient first. Whether it is a surgical correction of the airway, when there is an airway block, we have to open the airway. That is what we have to do. How to open the airway? If the obesity is there, see, it is all, fragmented approach we are having even now in our all the places, pulmonologist treating, cardiologist treating, neurologist treating, and so many other people are tackling these, and they are presenting themselves as the sleep medicine specialists and all. But there is no team approach. That is what we have seen. So when we decide who should take first, based on what criteria we have to decide, all those things I will come to that next. So snoring, what is snoring and obstructive sleep apnea? The definition is, see, it's one of the sleep related breathing disorders. One of them. All the other sleep disorders, we know that classification is there. I don't want to go into. OSA is sleep-related breathing disorder characterized by repetitive episodes of apnea and hypopnea, that is cessation of breathing, complete or partial. Hypopnea is partial. And then upper airway obstruction during sleep due to that. And in spite of the patient struggling, they will be struggling to breathe, but they cannot open the airway. That's what happens. And the definition of apnea, hypopnea, apnea is 10 seconds of cessation, more than 5% of desaturation will be there. And hypopnea is 3 to 4% of desaturation with a partial block, airway block. There are a lot of things, we study in those things. So I want to tell you that it is no more a laughing matter. Definitely everyone knows now, awareness has come. And our loved ones, I think we are lucky in India, but abroad they are giving divorces. They don't consider it as a love song, snoring. So incidence, the snoring is about 30 to 50% of the population above 40 years of age, but everything is not serious, severe obstructive. They won't go into obstructive sleep apnea. Everyone. The 2% of women have got and 4% of the men are double the number, will have the moderate to severe where they require definite intervention. But even milder ones also now we came to know that there is a syndrome called upper airway resistance syndrome. So partial block, even less than 3 to 5% of desaturation happening, even for them, they will go into a long term, they will go into these kind of consequences, including not only obstructive apnea, they can go into, even without complete obstructive apnea, they can go into metabolic problems, obesity, metabolic problems related comorbidities, all the diseases, they can go into that. So all the snorers, partial block also, there is upper airway obstruction problems, they have to definitely consider this. So what is happening exactly is the airway here that collapses, pharynx level, upper airway. There are 4 levels from nose, level 1, level 2 is a palate and oropharynx, and then level 3 is a tongue, and level 4 is a larynx level. This is upper airway curve. So when there is a narrow, already the narrowed airway because of either anatomical problems in the nose or in the throat because of the obesity, fat deposition, the narrowed airway, when they breathe, they try to struggle and breathe fast, the air goes very rapidly and it will create Bernoulli phenomena, we know. Because of that, it will collapse and pull the tissue concentrically and further aggravates in the long run with the deposition of fluid and inflammation and the deposit of fat and all those things. Such things will happen. That is the mechanism. So the causes, I said, obesity and age above 50, male more common, and irregular sleep habits, all those things will be the complicating compounding factors. Anatomic factors, these are mostly very important for us surgeons, particularly upper airway surgeons like ENT, maxillofacial surgeons. We deal with the surgical correction of the anatomical blocks. And like tonsils, these snorers, originally even though their airway and upper airway anatomically normal, over a period of time, because of the fat deposition, the palate, uvula, base of the tongue, everything becomes, swollen, bulky, and they cause narrowing. These structures also we address, not only that deviated nasal septum kind of things and polyps, very clearly seen polyps in the nasal cavity, sinus diseases and all those things, allergies, we deal with them. So we have to deal with the obstructions like that as surgeons. Later on, to sustain our team leaders like Murthy and the physicians, they have to do everything. So who should do first, who should do next, that is what the criteria we have decided after experience, deliberating experience. So this is how the patient looks with the classical snorers and OSA patients with the facial and fat deposition around, and the throat, you see, over my crowded throat with the uvula, big huge tonsils, huge tongue, and the palate also, redundant mucosa, and all those things will be there. So this is the situation, as the parapharyngeal fat and the parotids also, they become like this. and they all constrict. Sometimes we advise even parotidectomies. Cherubism, we know that. Some people will have those things. To relieve the obstruction, we require surgical procedures like that. Our physician friends should know these things. As a team, we all should know each other, each aspect, so that we can comprehensively manage the patient for the best outcomes. One single ourselves we cannot get the total result, and total result will not come only with these things. So this is law. That is why. So why does OSA increase fat in the regions? I told you already. There is a regional distribution of the fat. OSA patients often have excess fat around in the tongue, parapharyngeal space, and the submental area and neck fat. Mechanism is intermittent hypoxia causes inflammation, and this inflammation alters the fat metabolism. I think Dr. Murthy will go more deeper in that. So the neck circumference is very important factor which we take. A neck circumference in male people, if it is more than 17 centimeters, 17 inches, and in female if it is more than 16 inches, a very important factor in considering about the intervention for those patients. And abdominal at the umbilical level, abdominal circumference also very important. So this is how the fat gets deposited, and obese with OSA and obese patients without OSA, there were studies like this. So when there is no OSA, the fat was not there in the neck circumference. You can see that OSA people will have this kind of a larger deposit of fat in the tongue and the parapharyngeal area, all these areas, parotid area, we see that. Visceral fat also will be markedly increased in OSA patients. Some people, though they are obese, they will not have obstructive airway syndrome, like oxygen desaturations and all will not be that much, though they will be very heavy. We see in our experience also. For them, the fat deposition will be only subcutaneous levels, probably. That is how it is observed. So, what can happen with the snoring? As I told you, we already know in health ramifications, lot of health ramifications. We know that all those aspects. I think Murthy Garu will go into details. The symptoms will be morning headaches and daytime sleepiness, loud snoring. These are the very important symptoms: loud snoring, gasping during the nights, morning headaches, daytime sleepiness. One of our patients whom we have treated, Radhika, will tell, he comes to Hyderabad from Nizamabad, 10 or 15 times he used to stop car and sleep and come back again. Some patients met with accidents. We have seen like that. We all know those things. So went to consult, as I told, very loud snoring and stopping breathing by partner, gasping, daytime sleepiness. These are the things. These are the evaluation forms, different kinds of evaluation forms in the literature. But ultimately, after going through the subject thoroughly, I have designed a way which is more appropriate, I thought, for our center. This is my design. I coined my name, Dr. Mohan's OSA assessment form. I think Dr. Radhika will be dealing with that details, how we are doing. So the level of obstructions and diagnosis, all the tests what we go into is clinical and the nasal endoscopy we do to locate the cause of obstruction, disease or anatomical structural problems, DNS and all. At what level is the main obstruction, we have to find out. Otherwise, the procedure, surgical procedures, if we don't target to the main obstructive element, whether it is tongue base, whether it is in the nose, whether it is in the uvula, palate, or in the larynx. Sometimes we have seen epiglottis blocking, collapsing and all. So the polysomnography is a gold standard evaluation. I cannot go into all the details now because of short of time. So oxygen saturation level and nasal airflow, degree of respiratory effort, EEG, electrocardiogram, all these things, parameters we take into consideration to assess the risk in such a patient. in a patient, whom we have to immediately go intervene like that and alert them. So this is how we classify the apnea hypopnea index classification. It's less than 5 events we call the apnea hypopnea events in a 1 hour sleep. If they are less than 5, it is normal. If it is 5 to 15, it is mild. 5 to 15 times of 10% of 10 seconds of cessation of breathing. They will stop breathing and they suddenly, after stopping, the oxygen falls, carbon dioxide accumulates, and that will drive the brain to arouse the patient. The brain will, we know that carbon dioxide stimulates the carotid receptors, and it will create, in turn awaken the patient, and suddenly he will turn like that, struggle like that, and again start breathing like that, gradually increasing this snoring loudness. We know that if you see a sleeping patient, we know that. So 15 to 30 times if they stop, it is moderate, and more than 30. We have seen patients who had 175 times stopping breathing also, even more number of times also. Snoring events, 1,000 times of this thing. So mild, moderate, severe based on the number of apnea and hypopnea events and saturation levels also. We combine that, when there is a 86% of level or more, not less than 85% of oxygen desaturation, it is mild. If it is more than below 85, that is 80 to 85, moderate, and then if it is below 80, if it is, that will be considered as severe kind of desaturation. So the treatment protocols, there is a thing called CPAP. I think many of you know. It's a continuous positive airway pressure machine. We will provide with a mask and all. The person has to sleep like that. One of my friend, the close friend, he is very happy for the last nearly 25 years he is using, but it is not same with every patient. We find complaints in less than 70%, and not even like 70. We have seen 50% of the people only can adjust. That also for in the long run, even that number also will become less. So lifestyle modification is very crucial part. That aspect Dr. Murthy garu will deal, and surgical treatments are important. So I said palatal surgeries we do like this: UPPP, uropalato-pharyngoplasty, laser-assisted palatoplasty, cochlear-assisted tongue-based reduction, epiglotopexy, adenoids and tonsils in children. Very, very important in children. Please remember this. If you have your own family members and friends, any child having noisy breathing, immediately we have to attend with sprays, nasal sprays, warm steam inhalations and all those things, and we can also subject them for oxygen saturation levels, how they are going, with the oximeter also we can see. Nowadays I think in the cell phones also the apps have come. We have to see if there is a grade 1, grade 2 adenoids and tonsils. We don't advise surgery, but definitely grade 2 to 3 and 4, 3 and 4 definite surgery. 2 we have to follow, observe those people, children. So this is how the throat looks, the snorer's throat is normal, and see this, how narrow it is. Lateral pharyngeal walls also got collapsed. This is how the epiglottis, this is epiglottis there. See how bulky it has become. Entire tissue, pharyngeal mucosa, bulky it has become. And we do the DICE, that is drug-induced sleep endoscopy. We give propofol in a low dose, 1 milligram per kg body weight, like that we give induce and make them sleep. While sleeping, we introduce the endoscope and evaluate the level of obstruction. This is how we do this evaluation with the sleep endoscopy. I think you can see that. See, that is the this is the epiglottis. See the epiglottis, how it is collapsing. This thing we cannot see without doing endoscopy. Now, this sleep endoscopy is the gold standard. to identify the place where. See, that is how it is obstructing the airway. It is collapsing. These people cannot be benefited by just only nasal surgery. We have to do palate, also epiglottopex for them. This is how we see how the saturation falls and all those things. No, we see them. So these are the surgical procedures we do. These are there are a lot of modifications and evolution in the surgical procedure. Depends again the patient's palate, type of palate, and type of pharynx, lateral pharyngeal wall collapse, or the anteroposterior collapse. Depending on those things. So this is a classical one earlier. No, the first one UP3. Entire uvula and soft palate was resected and sutured like that. Nowadays we don't do that like that. We have modified them, refined them. With the barbed wires also we are strengthening the palate, soft palate, and this is how the after surgery looks. Earlier we have seen the uvula, palate, how bulky it was after removing the tonsils, and the uvula also. I have developed, I think Radhika was appreciating me. I have not seen before this uvula reconstruction, because it will be totally removed in all the procedures by the people except for the palatal strengthening. When we do uvulopalatoplasty, they remove the uvula. So when we remove the uvula, there will be dryness in the throat and there will be foreign body sensation. So I started reconstructing it, and this is how it looks with a small uvula and nicely there are so many other modifications, tongue base with the radio frequency, we reduce the mass like that, and so many things. Details I don't want to go. This is adenoids. With the debrider, I started first in Hyderabad to use the debrider endoscope. See, that is the adenoid, how it is blocking the coina, posterior nasal aperture. It is totally blocking there. I use the debrider and endoscope. I remove the adenoids. Later, when we see, it will be nicely opened up. See, that is how I use the debrider, and just to give an idea for you, after completing that, it will be put. And at the same time, I do the grommet for the ear. And this is the uvula. See, that is how I resect the uvula partially and create some flaps from the side and then reconstruct the uvula. That's how I am doing, using the radio frequency needle. That's how the uvula. See, that is the uvula. I am holding the uvula and reconstructing that later. So, to summarize, it is a vicious cycle of obesity and OSA. So obesity and OSA reinforce each other, and they go into a self-perpetuating cycle. So OSA fatigue like that, by hormones and all those things, Murthy Garu will go. And OSA is not just obesity. It is not just obesity, what I mean to say. Weight loss alone doesn't cure OSA. These interventions are very important. That's what I want to stress for the people, physicians, especially, we need a comprehensive combined team approach, including our nutrition specialists and also behavioral specialists, behavioral modification specialists, to motivate constantly. We know that we ourselves cannot follow the things for a long term unless somebody will be constantly friendly, motivating words we need, and that is very important. I always say that even Tendulkar needs a coach constantly. They sometimes say, no, you go now, go and bat, run. They will say like that also. So we need those team people all. So weight loss alone doesn't cure OSA, but weight loss even to the extent of 5 to 10% can cause clinically significant increase. What I mean, weight increase. Even 5 to 10% cause significant recurrence of OSA after surgery. That means weight loss is important. But the opposite is also true. Surgical restoration of upper airway plays a big role in maintaining the patency of the airway, and simultaneously when the team deals with the patient, the compliance and all will be very good, and sustaining results will be there, and better long-term airway patency, and the CPAP compliance also will be definitely. CPAP with the nose, obstructed nose and polyps definitely those are obvious things. He cannot, even if the machine which pumps also, the air won't go in a blocked airway with the big tonsils and all. So that is very important, and metabolic to relieve of that. So to conclude, OIS is a complex disorder. All the treatments are only moderately successful if they are applied alone, or if they are applied alone, they are only moderately successful, including lifestyle medicine or surgeries also. So we have to combine. So once again, to conclude with these words, thank you.